Dear colleagues, dear students, we continue the psychiatry education from the University of Page, Department of Psychiatry and Psychotherapy. We are at the fifth year and first semester, and this is a lecture on somatophorm disorders, which is recently called somatic symptom disorders in the DSM-5. And we will deal today with obsessive-compulsive disorder and related disorders. So this is the topic of our today's lecture. First of all, what somatophorm, or other term, somatic disorder, somatic symptom disorders means. Somatophorm disorders, by definition, means that there are somatic symptoms which exist. There are somatic complaints which exist, but there is no any real somatic background. So the patient develops a paralysis or paralysis, and there is no central nervous system background of this symptom. And this is why it is called somatophorm, somatic-like disorders. So this is the simple definition, and later we will deal in details with this problem. Hysteria and hypochondria are known from the antiquities, so there is a long history of these problems, that somebody developed some kind of somatic symptom without any real organic background, or hypochondria means that the patient has an intensive fear and intensive anxiety connecting to illnesses which do not really exist. The term hysteria was introduced by Paul Briquet in 1856, and Charcot, a great neurologist, introduced the neurology of hysteria. He was a neurologist who introduced the different forms of hysteric symptoms, sensory loss, paralysis, hysteric blindness, hysteric deafness, and other hysteria symptoms which we shall see in the next minutes. Sigmund Freud, the establisher of psychoanalysis, very much contributed to the understanding, to the psychological understanding of hysteria. He discovered the role of the unconscious behind the hysteric or convulsive symptoms. For example, in a case of a female patient who had paralysis of the left hand, he could explore with hypnosis and with dream analysis that there were unconscious, aggressive tendencies towards the patient's father, and the hysteric symptom, in a symbolic way, expressed the unconscious content. So the female patient unconsciously wanted to kill the father, which she was not able to make conscious because it was not couldn't be accepted by cultural norms, and this led to the introducing of the hysteria symptom, and this is what the role of unconscious and the symbolism of the symptoms means. Many times Freud could identify sexual conflicts behind the symptomatology. Thomas Sydenham, whose name is also known from neurology, introduced the term hypochondria. This is a very famous picture, and you can see Charcot at the Paris Salpêtrière hospital, who is showing a famous patient, famous female hysteria patient. The patient shows hysteric somatic symptoms, and there are very famous doctors who you can know from the history of medicine. For example, Gilles de la Tourette, who introduced the Tourette syndrome, who discovered the Tourette syndrome, or you can see Babinski, who is staring at a woman, a female patient, the Babinski sign, or Ribot, who is a very important person in the psychology of memory processes, or you can see Bernaville, who we speak of after whom we speak about the Bernaville syndrome, the sclerosis tuberosa, and many famous doctors can be seen in this picture. And you can see here the picture of Sigmund Freud, who very much contributed to the psychological understanding of hysteria and somatophorm disorders. One of the first books of Freud's was the Studies on Hysteria, which he published with Breyer, which very much gave information to the psychological understanding of hysteria symptoms. The somatophorm symptoms, by definition, means that the symptoms can't be explained by our current biological and physiological knowledge. The concordance of monozygotic twins is 29%, while in the case of dizygotic is 10%, so you can see that there is some contribution of genetics here, but it's not so much. Endocrine as cortisol and immunological higher cytokine levels, differences can also be found. Mild deviations of the somatosensory input as discrete memory and attention function disturbances also can be identified in this case of these patients. There is a higher psychophysiological activity level of patients who evaluate the physical signs in a distorted and exaggerated way. So there is an exaggerated monitoring of body sensations, we can say, and this leads to the symptomatology of the patients. There is a phenomenon which we call chronic patient behavior, which means a secondary disease gain after Freud, and this is a very important characteristic of these patients with somatophorm disorder. What does it mean? Freud spoke about the primary and the secondary disease gain. By primary disease gain, Freud spoke about a phenomenon which means that a pathological but existing balance appears in the symptomatology, in the symptoms in the patient's psyche. So, for example, if a patient has an unconscious aggressive tendency towards the father, and the patient cannot repress it totally, and the patient cannot make it conscious, and there is an anxiety, there is an inner conflict, there is an intrapsychic conflict because of this aggressive tendency and because of the incapacity to repress it and the incapacity to make it conscious. And this intrapsychic conflict is resolved somehow by the hysteria symptom, by the conversive symptom, by the paralysis, by the somatophorm symptom. So this is what Freud meant by primary disease gain. It means that the intrapsychic conflict is somehow solved in a pathological way, but in a pathological way it is solved and the patient develops paralysis of the left hand, which is a symbolic expression of the patient's unconscious wish. This is the primary secondary gain. The second primary disease gain. The secondary disease gain means that with the appearance of a symptom, the patient gets increased attention by the environment. If we are ill, we get more attention from our parents, from our partners, from our children, etc. And this is what secondary disease gain means. And in the case of somatophorm patients, this secondary disease gain is chronicized and it leads to chronic patient behavior. The patient tends to remain in the patient role because he gets more attention, and this is very characteristic of these patients. Stress, trauma, and sexual abuse many times appear as a background of these symptoms, and there is an increased attention to physical symptoms in the case of these patients. Let's see that in the DSM-5, which are the somatophorm disorders or somatic symptom disorders. The first is conversion disorder, we shall see later the details. In conversion disorder there are paralysis, sensory loss, and different symptoms around the sensory organs. Hypochondriasis, when the patient has an intensive fear from illnesses. The patient has a fear from cancer, the patient has a fear from another serious illness, and then the patient goes to a medical doctor, and when the patient gets negative results that there is no existing illness, the patient changes the symptom and starts to fear from another serious illness, and this is what hypochondriasis means. This is an illness, the recent term which is used in the DSM-5 is illness anxiety disorder. Somatic symptom disorder, which is also previously was called somatization disorder, when there are different discomforts, pains appear in the different regions of the body, nearly and mainly in the field of the vegetative nervous system, and this is many times a chronic illness. Somatic symptom disorder predominantly with pain. Earlier this was called psychogenic pain disorder. Then the next somatoform disorder is neurasthenia, when the leading symptoms are irritability and fatigue. Fibromyalgia, bone and muscular pain. And chronic fatigue syndrome, which often occurs after viral infection. And for the diagnosis of a chronic fatigue syndrome, the duration of the symptoms should be longer than 6 months. What are the most important characteristics of conversion disorder? Here we can see motoric symptoms, paresis or paralysis, without any CNS disorder, and these paresis and paralysis do not follow the characteristics of the central or peripheral paresis, which you learn and which we know from neurology. There can be abnormal movements, as tremor, dystonia, disturbance of walking. Aphonia or dysarthria can appear also. Sensory loss, the different regions of the body. Loss of vision, hearing or smelling ability, which is called conversive deafness or conversive blindness. Previously it was called hysteric deafness or hysteric blindness. Functional seizures, which mimics epilepsy. And here you should know that in the case of real epilepsy patients, these functional seizures can appear, and it's very important to differentiate the real epileptic seizure from the functional seizures. But functional seizures can appear also in patients who do not have epilepsy. And labile indifference as a characteristic symptom in conversion disorder, which means that it's a French term, which means nice indifference, that the patient, for example, says, I got blinding, and he smiles, she smiles, and it doesn't follow the characteristics of a real organically based blindness, and this is as a conversive sign many times can be seen in the case of these patients. Somatization disorder means that there are a variety of symptoms that last for more than 6 months, so it's a long duration, and there are discomfort, pain, continuous occupation with symptoms, and anxiety of the origins. Patient has different discomfort in the abdomen, in the chest, or different parts of the brain, of the body, and many times the patients are seriously worrying about the nature of these feelings, and anxiety is there. The treatment of somatoform disorders are psychotherapy and pharmacotherapies. In psychotherapy, supportive patient guidance is important. Evaluation of a psychological insight is very important. The patient has an exaggerated, increased somatic insight, and we should decrease it and introduce a psychological insight on the illness, that you do not really have a somatic illness. We should decrease the insight on the somatic problems, and we should increase that instead there is a psychological problem, and we should increase the psychiatric or psychological insight of the patient. It's very important to reduce anxiety, and psychodynamic exploration in some cases can be introduced. For example, if there is a classically symbolic symptom at the background of and we can make a psychodynamic interpretation after a time, and we can introduce for the patient a kind of explanation on the unconscious background of the symptomatology. Pharmacotherapy can be antidepressants and anxiolytics. The next group of illnesses I'm talking today are obsessive-compulsive and related disorders. Obsessive-compulsive disorder means that the criteria of this disorder that the symptoms occupy the patient more than 1 hour per day and significantly disturbs the patient everyday functioning. Obsessions, as you know, are irreal thoughts the patient repetitively needs to think again and again. Compulsions are repetitive acts the patient repetitively do again and again, and it can be very much serious, and this is what we speak about in this disorder. The fourth most common psychiatric disorder is OCD, Obsessive-Compulsive Disorder, with a lifetime prevalence of 1 to 3%. There are subclinical forms or subthreshold forms of which are more common. The subclinical OCD symptoms can be found in 13% of the population. So these symptoms do not fulfill the diagnostic criteria of obsessive-compulsive disorder, but can exist. For example, somebody somebody sometimes wants to count something which is not so disturbing, which lasts only for a few minutes, and it doesn't fulfill the diagnostic criteria. It's not so much disturbing, it's not so long, but the patient needs to count in a room, for example, how many chairs are there. He needs to count it 3 times and then he gives up. And this is somehow an OCD-like symptom in a subclinical or subthreshold form, which doesn't fulfill the diagnostic criteria of OCD. And it's, as you see, it's really frequent. Obsessions are repetitive, intruding thoughts or images that can cause anxiety and suffering. And the patient is aware of the irrationality of these symptoms, and the patient tries to suppress it and replace them with other thoughts and directions. These are obsessions. Obsessions can be aggressive. The patient needs to think about the death of somebody or killing of somebody. Contamination, sexual contents again and again, religious contents, or the patient needs to think about symmetry again and again, and these are the most important forms of obsessions. And the compulsions can be connecting to cleaning, to controlling, to repetition, counting, collecting, and hoarding. So these are the most important forms of compulsions. For example, the patient needs to check the gas again and again, whether it is closed or not. The patient needs to control the door, whether it is closed or not. The patient truly knows that the door is closed, but needs to go back from the corner of the street again and again back, and check again and check again and check again, and this doesn't let the patient to go to work, and it very much disturbs the everyday functioning. So these can be very serious. These symptoms can be very serious. The etiology of obsessive-compulsive disorder is more and more neurobiological. In the beginning of the 20th century, psychoanalytics gave many important explanations to this disorder. We see the obsessive-compulsive disorder more and more from a neurobiological perspective. So let's see a few data on this. Among first-degree relatives, the prevalence was significantly higher. It's 10 to 20%. In the case of monozygotics, the concordant rates is 63%, while in the case of dizygotics is 8 to 15%. Certain regions of chromosome 1, 3, 6, and 7 and 15 are related to OCD. There are many imaging studies, structural and functional brain imaging studies, which gave information to neurological background of the disorder. Structural brain imaging studies found differences in the prefrontal region and the basal ganglia, the thalamus and the hippocampus, while functional brain imaging studies demonstrated the dysfunction of neural circuits between the prefrontal lobes and the basal ganglia. Also, serotonergic activity was reduced in the midbrain regions of OCD patients, and this is why the knowledge that SSRIs are effective in this disorder is connecting to this data, while also dopaminergic dysfunction is also known. For example, amphetamine and cocaine, which are dopamine agonists, worsens these OCD symptoms, and encephalitis affecting the basal ganglia and Tourette syndrome can cause OCD symptoms. So the dopaminergic dysfunctionality in the midbrain region, in the basal ganglia region, are connected also to the etiology of the illness. There are some psychological mechanisms which can be identified. For example, recent self-psychological theories emphasize the role of ambivalence and the fragmentation of the self. Certain parts of the self is isolated from other parts, and this isolated self leads to the recurrent appearance of symptoms. So we can say that there is an island in the self, there is an isolated, not connected island in the self, which is somehow connected to the symptoms in OCD. According to the learning theory, the compulsive symptoms is an active avoidant behavior given as a reaction to anxiety that is straightened and fixed by the anxiolytic effect. The therapy of OCD, the therapy of obsessive-compulsive disorder, is also complex. So we can see psychotherapy and pharmacotherapy as two basic treatment approaches. In psychotherapy, the most recently used and most widely used therapy is cognitive behavior therapy. In the first part of this 20th century, it was psychoanalysis. Now more cognitive and behavior therapy, which clinicians use. And there are different forms. For example, exposure therapy, when we expose the patients to the anxiety-provoking situation, or desensitization, when we develop a gradual tolerance to the anxiety-inducing situation, and also thought-stopping techniques can be used in OCD. So, for example, in the case of exposure therapy, if the patient has a fear from dirt, then we put the patient in a situation when everything is dirty, and it's a kind of exposure of dirt to the patient, which can very much decrease the pathological symptom behavior. And from pharmacotherapy, as clomipramine, SSRIs, antipsychotic, and benzodiazepines can be mentioned. You know that clomipramine is a tricyclic antidepressant. We do not really use tricyclics in the case of depressive patients, which you shall see that other more modern drugs are used in the treatment of depression. But in the case of OCD, clomipramine remains a choice and remains an option, because in some cases patients do not respond to necessary antidepressants, and in these cases clomipramine is still useful. Selective serotonin reuptake inhibitors, in the case of many patients, are helpful. In some cases, when antidepressants do not work, antipsychotics can be introduced, mainly risperidone. In some case reports, olanzapine, in some studies, quetiapine, aripiprazole were effective. The most important antipsychotics we can add to the treatment of OCD patients is risperidone, and benzodiazepines also a possibility. In the case of treatment-resistant patients, neurosurgical procedures can be introduced, and two techniques. One is the laser methods, as anterior capsulotomy and cingulotomy, or deep brain stimulation treatment, which you learn from neurosurgery and from neurology, which is a treatment for Parkinson's disease and other neurological illnesses, also can be used in OCD, and anterior capsular stimulation and nucleoscopal stimulation can be used in the case of deep brain stimulation. Another related disorder is body dysmorphic disorder, which means the preoccupation with one or more perceived defects in physical appearance that are not observable or appear slight to others. The female patient believes that her breasts are too small and wants to go to have a plastic surgery, or her nose is too big and not nice and wants to get plastic surgery, and the plastic surgeon or the other doctors feel that here is some problem because everything looks quite normal and quite average anatomical variation, and the patient doesn't accept it, and as a body image problem, the patient has a a kind of discomfort around his or her body, and this is what appears in body dysmorphic disorder. And the patient visits a plastic surgeon or dermatologist and seek for treatment, and in most of the cases, complex treatment, psychotherapy, and antidepressants can be introduced. If this lecture would be in a lecture hall and there would be an audience, I would ask that please tell me what can be the diagnosis of this patient whose flat we see here. And the correct answer would be hoarding disorder. Hoarding disorder, which means a persistent difficulty discarding or parting with obsessions regardless of the actual value. The patient collects many unvaluable objects which leads to hygienic problems, and this is what we see here in hoarding disorder. Normal living in the apartment becomes impossible, and there are serious hygienic problems which develops in the case of a patient whose flat is like this. You should exclude the case of chronic psychosis, dementia, or autism, which represent a differential diagnostic issue here, because in the case of hoarding disorder, these are not the diagnoses. These should be excluded as differential diagnostic options. Again, if we would be in a lecture hall and there would be an audience, my question could be that what is the diagnosis of this patient, what can be the psychiatric diagnosis of this patient with this serious hair loss, and the correct answer would be trichotillomania, which means a recurrent pulling out of one's hair resulting hair loss. Alopecia may develop. Hair, eyebrows, eyelids, and pubic hair regions may be affected. Anxiety decreases after pulling out of the hair. In many cases, there is an increasing arousal in the patient to pull out the hair, and the patient pulls out the hair, and the anxiety and arousal is decreasing, and this is how the symptoms develop. In 40 to 50% of cases there is also trichotillophagia. The patient eats the hair, which can lead to illness and trichotillobezala. The therapy are SSRI and CBT, so pharmacotherapy and cognitive behavior therapy can be used in these patients. And with this, I would like to thank your attention and finish the lecture today, where I have summarized the most important knowledge of somatophorm disorders, OCD, body dysmorphic disorder, hoarding disorder, and trichotillomania. Thank you.